ultrasound to study the pulmonary parenchyma. But if we get the 2015 recommendation on pre-hospital and early management of acute heart failure from the European Society of Cardiology, so a very important document, we can find that the echo of the lung and the heart is part of the diagnostic tests in the algorithm of suspected acute heart failure. So there is a huge discrepancy here, and who should we believe? So this discrepancy is based on the fact that it is true that the ultrasound beam is dissipated in the air, but it's not true that these cannot have an important and meaningful information from a clinical point of view. And for example, if you take a lung which is normally or over-aerated, so not necessarily a normal lung, but just an aerated lung, and you put a probe on it, what happens is that the acoustic mismatch between the air and the surrounding tissue is so strong that the overall ultrasound beam gets reflected back. So if there is air in the lung, we are able only to see this hyperechoic horizontal line, which is a pleural line, and then we don't see anything more. It's like that the pleural line is a hindrance. And I believe Giovanni told you many things about this yesterday. But what happens when we start losing this air content in the lung? So if you have a disease in the lung and the air is replaced by a trasudate or an exudate or by blood or collagen tissue, the acoustic properties of the lung changes. So the very high acoustic mismatch is no longer there. And what happens is that the ultrasound beam is now able to partially penetrate the lung. And what we see are these hyperechoic reverberation artifacts that are vertical, that arise from the pleural line and go down to the edge of the screen. And they are called B-lines. And as you can see here, the less air you have in your lung, the more B-line you see, okay? Until you have a kind of sonographic picture of a white lung. And if you lose even more air content, you may change from this world of pulmonary ultrasound artifacts, which are anyway meaningful from a clinical point of view, to the world of the direct visualization of the pulmonary parenchyma. So, for example, if you have a consolidation, you actually see the consolidation. You see the consolidated parenchyma. And if we change to moving videos, you have the world of the aerated or over-aerated lung, where you only see the moving pleural line, and sometimes you may see the A-lines. You have the partially de-aerated lung, where you have the B-lines, and you may have separated B-lines or more coalescent B-lines. And then you have a completely de-aerated lung when you have a consolidation like this one. So this is why we call the lung ultrasound a densitometer. This is the main concept, which is very important to understand what we can see by lung ultrasound. Okay, it is a way to assess how much air we have in the lung. So for a cardiologist, the most interesting part of lung ultrasound is B-lines, okay? Because B-lines can be found in heart failure. B-lines are a sign of interstitial pulmonary congestion, interstitial edema. And this is the definition of B-lines. So again, they are discrete, laser-like, vertical, hyperechoic reverberation artifacts that arise from the pleural line and go until the edge of the screen. And they are the sonographic sign of the pulmonary interstitial edema. That's why us cardiologists like the lines so much. And this is the definition that has been given during the first consensus conference on pleural and lung ultrasound that is going to be updated very soon. So when you can use lung ultrasound if you are a cardiologist? The answer is very easy, and it's always, okay? This is why it is so useful. So if we consider a patient with a heart disease, we can use the B-lines for diagnosis, for the monitoring, and for the prognosis. So for the diagnosis, maybe this is the field where we have more solid data, because it was the first field of application lung ultrasound. And it's very typical to use lung ultrasound for the differential diagnosis of acute dyspnea. And it's specifically useful to differentiate cardiogenic pulmonary edema from other causes, and especially one of the most common causes of acute dyspnea, which is COPD exacerbation. So this paper dates back 20 years now. It was 1998 when Daniel Lichtenstein, that we all consider a kind of father of lung ultrasound, published this data saying that the B lines that at the time were called the comet-tail artifact could differentiate these two conditions. So COPD exacerbation, you don't see B lines. Cardiogenic pulmonary edema, you see the B lines. It's very important, and I like to stress this point, because if it's one of the first time that you are using lung ultrasound and you have a patient with acute dyspnea with a few B lines, you don't have to rush to the point that this patient has a cardiogenic pulmonary edema. And why? This is because it's not only B lines. We have to give some more definitions to the presence of B lines. So when you have acute heart failure, you have multiple diffuse and bilateral B lines. Multiple means more than 3 B lines, at least 3 B lines in one single scan. Diffuse means in more than one spot in a hemithorax, and bilateral means both on the right and the left side. Okay, so in COPD you may find a few B lines, but they're not multiple, they're not diffuse, and they're not bilateral. But you may see a few B lines, okay? So this is very important. It's not only B lines. You have to use these 3 adjectives for the acute heart failure. And this is why, again, we see this slide, lung ultrasound was put in this algorithm for suspected acute heart failure. And if you see the position of lung ultrasound, which is together and even before the heart ultrasound, this is a big revolution, okay? And this is also why in the last 2-3 years, we had lung ultrasound and B lines in many recommendations and guidelines, especially European recommendation papers. So for example, this paper is about the use of echo in acute cardiovascular care, and you can find that in both acute systolic and diastolic heart failure, interstitial edema may be diagnosed at bedside by B lines, by sonographic B lines. So again, a big revolution to have lung ultrasound in these recommendation papers. And even the 2016 guidelines on heart failure, the European guidelines, for the first time mention lung ultrasound. And they say, again, bedside, and this is an important word that is coming again and again, bedside thoracic ultrasound for signs of interstitial edema and pleural effusion. Of course, we don't give up to scan pleural effusion, may be useful in detecting acute heart failure, okay? They add if the expertise is available, which is, again, quite a paradox, because if there is a thing that is not an issue about lung ultrasound is the expertise, because it's very easy. But since it is not yet widespread so much, they had to add this sentence. And again, we have lung ultrasound also in this emergency echo recommendation paper. And I think this sentence is very interesting because it underlines a very important property of B lines in acute heart failure, which is the very, very high negative predictive value. So they say that the absence of multiple bilateral B lines exclude cardiogenic pulmonary edema with a negative predictive value which is close to 100%. And this is very important because we will see that B lines are not so specific. They are not just a sign of cardiogenic pulmonary edema. They are a sign of partial deaeration of the lung, but they are extremely sensitive. So even if you're not very good at lung ultrasound, if you have a patient with acute dyspnea and you don't see multiple diffuse bilateral B lines, you can actually exclude 100% sure that this patient has dyspnea because of water in the lung. The patient may still have heart failure. The patient may still have increased left ventricular filling pressure, but there is no extravascular lung water. And this is, from a physical point of view, very, very robust. And another interesting consensus statement is this one published last year, and it's very important because they put together echocardiography and lung ultrasonography for the assessment of acute heart failure. And this is a very important concept for cardiology. So we feel very lucky because we have the cardiac probe in our hand that we have been used for years to scan the heart, and we just have to move it a few centimeters above the heart, and we can see the lung. We don't have to change anything. So actually now as cardiologists, we are able to perform a cardiopulmonary assessment, an integrated cardiopulmonary ultrasound assessment. So again, it's used for diagnostic monitor response in acute heart failure. So from a practical point of view, it's true that if you see a patient with this kind of heart, this is a parasternal long axis view, this is the left ventricle, the mitral valve, the left atrium, the aortic valve. So in this case, if you have this patient coming with acute dyspnea, it's not so difficult to guess that this patient may have an acute heart failure. The same we can say if you see this aortic valve, which is fully calcified, so this patient has likely a severe aortic stenosis, and again, you can expect to have B-lines, you can expect to have extravascular lung water. But when you see this heart, so you actually have a normal preserved ejection fraction, maybe the left atrium is a bit enlarged, but there is nothing really striking about this heart, okay? So if this patient comes with dyspnea, and maybe this patient may have a heart failure with preserved ejection fraction, it's very nice if you see the B-lines because you feel much more confident. So this is a real cases that happened to me a few years ago in ambulatory office. It was a patient, 70-year-old with typical risk factors for coronary artery disease, and he had dyspnea in class 3 from about 1 week and a mild leg edema. So he went to the ambulatory office, he said, I don't feel well, I cannot breathe very well. This was his heart, and he actually had some typical echo signs of diastolic dysfunction, but I have to say that it's not so easy to assess diastolic function by echo, and you need some kind of expertise. So, okay, yeah, you can suspect the patient has a heart failure with preserved ejection fraction, but when you see this, you are quite sure, okay? So you see the B-lines, which are diffuse, bilateral, and multiple. And you may also find, as in this case, a very small pleural effusion in the right costophrenic angle. So again, when things are striking, lung ultrasound can still be useful, but maybe you don't need it. But when the cases are a bit more gray, so lung ultrasound is really, really helpful because it can give you a very powerful information with a very, very small effort. So there is another field where you can use B-lines as a cardiologist, but not only. And this is the differentiation from between cardiogenic and non-cardiogenic pulmonary edema. So these data, again, are not even very recent. This paper now dates 10 years ago, but this information is very simple and again very powerful. So actually, if we have a non-cardiogenic pulmonary edema, so like an acute respiratory distress syndrome, we also see a lot of B-lines, which can be bilateral, can be multiple, can be diffuse, although there are different characteristics from cardiogenic edema, but there is a very important difference, and it is the appearance of the pleural line. So cardiogenic pulmonary edema, you see a lot of B-lines, but the pleural line is very thin, it's very regular. In acute respiratory distress syndrome, the pleural line is usually very, very abnormal, okay? You see these hypoechoic, anechoic spaces below the pleural line. So when you see these, of course, it's not enough to make a differential diagnosis, but your suspicion that this is not cardiogenic should be raised, okay? And sometimes can be very useful. So we believe these subpleural alterations are the expression of the alveolar involvement of the non-cardiogenic pulmonary edema, which is also why you can sometimes see this appearance in the cardiogenic pulmonary edema, but only when it is very, very severe with a huge alveolar involvement. So this is important to be remembered. And again, of course, we don't have to forget that we can use lung ultrasound also for pleural effusion. And I think it is very useful for the cardiologist, but for any other physician, to use lung ultrasound when you see a radiopacity on chest X-ray and you don't know what the radiopacity is. So it's not so easy to give a report on a chest X-ray, especially if they're done bedside in critically ill patients, and sometimes radiopacity can be congestion, can be pleural effusion, can be a consolidation. If you put a probe, lung ultrasound will tell the difference very easily, okay? You don't need a big training to see that this is consolidation and this is a big pleural effusion with a compression atelectasis inside. So again, very easy, but very informative. So again, if we go back to this differentiation between cardiogenic and non-cardiogenic pulmonary edema, which can be sometimes not so striking and not so easy, of course, the clinical setting remains the basis of all of our differential diagnosis. This is not only true for cardiogenic and non-cardiogenic edema, this is always true. We use the ultrasound with the clinical approach, okay? The B-lines distribution can be important to differentiate these two conditions because the cardiogenic edema has a dependent related distribution. So you have more B-lines in the dependent areas at the basis of the lung or along the axillary lines if the patient is laying down. Whereas in non-cardiogenic, in ARDS, you have a non-homogeneous distribution of B-lines. Okay, so you may find B-lines at the apex of the lung and less at the base. It doesn't follow the gravity. Another important thing, of course, as we have said, are these subpleural alterations, which are very typical. And of course, if you can add an echocardiogram, this can give you further information. But you may also have a non-cardiogenic edema in a patient with a coexistent heart problem, which is not the acute problem at the moment. And so lung ultrasound is useful in this situation. Okay, so we have done our diagnosis, but now we still need the lung ultrasound for monitoring our patients. And I think the monitoring is maybe the most exciting part at the moment, because there are a lot of papers coming out, and we are really starting to see how it can be useful in our patients. So we knew that B-lines could be very dynamic. We have this data, for example, from the dialysis. I know in the audience there are some nephrologists, and you may see B-lines significantly decreasing from the beginning to the end of the dialytic session. So a very quick change in the lung congestion appearance. And again, many years ago, already 13 years ago, we had this abstract showing that there was a significant change in the number of B-lines after furosemide in patients with heart failure. And Giovanni Volpicelli was the first one who published this, again, in patients with heart failure, showing that patients at admission had a high incidence of B-lines on the chest. This is the percentage of areas of the chest with B-lines at admission. And you can see that after a few days of hospitalization, this percentage significantly changed. And it's interesting to note that anterior and superior parts of the chest, so the apex, both on the right and the left, are the parts of the lung, the regions of the lung that have quicker clearance of B lines. Okay, so in the lateral basal, you still may have a few B lines even after 3-4 days of hospitalization, but you have less B lines in the apex. Again, for this gravity-related presence of B lines, and also the change of B lines follows the gravity, so they goes away before at the apex and then at the basis. And it's interesting, again, from a cardiological point of view, to see that B lines changes in a much more dynamic way compared to other non-invasive hemodynamic parameter that we can assess by echocardiography. For example, the pulmonary artery systolic pressure and E prime, which is an indirect sign of left ventricular filling pressure. So these two parameters tend to significantly change from admission to discharge, but there is not a significant change at T1 that in this study was at 24 hours. Whereas in B lines, we already have a significant decrease at 24 hours. So very dynamic sign. And we don't have to wait for 24 hours to see a change. In this paper by Chiara Cogliati and Francesca Coltellaro, we see a significant change already after 3 hours after administration of furosemide. And I can tell you that you may have a significant change even before 3 hours. It's nice that we are starting to have some data also about the prognostic implication and the outcome implication of this information. They're still very shy results, but this is something improving. So, for example, in this paper, they compared the discharge time, so how many days patients were hospitalized, comparing two branches, one who was monitored and followed up in the standard way, so by chest X-ray, and the other one who was followed up by lung ultrasound. And you may see that the patients with acute heart failure who were followed up during hospitalization by lung ultrasound had a significant lower number of days of hospitalization, so a smaller discharge time. And this is relevant also in economic terms. And again, these are interesting data about the prognosis of patients who are lung ultrasound responders or non-responders. So these Kaplan-Meier curves means that during an acute heart failure hospitalization, those patients who have a significant decrease of B lines have a better prognosis than patients who don't have a significant decrease in the B lines. So changing your B lines number matters during hospitalization. So I like this slide, who is modified by the late Mihail Ghiade, great expert in heart failure and in pulmonary congestion, because I think this is one of the key concepts of the use of B lines for cardiologists. So when we have a problem in the heart, so for example, we have an abnormal left ventricular function that can be systolic or diastolic or a valvular heart disease, we have an increase in the left heart filling pressure, okay? And we call this increase in the left ventricular filling pressure a hemodynamic congestion. But hemodynamic congestion, is different from pulmonary congestion, which is the increase of extravascular lung water. Okay, so this is pulmonary congestion and this is hemodynamic congestion. And to change from the hemodynamic to the pulmonary congestion includes a lot of variables. The hydrostatic pressure, the oncotic pressure, the permeability of the alveolar capillary membrane, the lymphatic drainage. So this means that you may have two patients with exactly the same ejection fraction, with very similar pulmonary capillary wedge pressure, very similar pulmonary artery systolic pressure, but one patient has B lines because has not only hemodynamic but also pulmonary congestion, and the other patient doesn't have pulmonary congestion, so doesn't have extravascular lung water. This is crucial for cardiologists because when you can visualize extravascular lung water by B lines, you can really have that meaningful information that can help you to guide the management of these patients. And again, going back to our patients, to our patient with heart failure with preserved ejection fraction, it's very nice to see that in that case we can use the lung ultrasound not only for the diagnosis but also for the monitoring. And if you see the difference between the day he came to my ambulatory office and it was the day when I didn't tell him to be hospitalized, I just increased his home therapy, and I told him to come back after 5 days. And after 5 days, all the signs of diastolic function were improved. I'm not going into details, but I can tell that they are improved. The pulmonary systolic pressure was lower, the vena cava was smaller and could collapse, and also the V lines, who were much more numerous on the 14th of August, were still present, a few, but less numerous on the 19th of August. So again, a very simple tool that can make you feel much more confident in the follow-up of the patient. This is an example of an outpatient, but you can have the same approach with inpatients, as we have seen with all these research papers that I have shown you. So in a way, we can say that if you have both lung and heart ultrasound, so if you perform an integrated pulmonary ultrasound, you have a way to assess both congestion and perfusion in your patient, which is something that you can do, of course, with the Swan guns, but this is accurate but very invasive. This is something that you can do with clinical signs and symptoms. This is much less invasive, but is also much less accurate. But you can do this with ultrasound, and this is a very good compromise between accuracy and invasiveness, and also from the point of view of the expertise that you need. Okay, so we can assess the congestion, we can assess the perfusion, and we can have a kind of non-invasive hemodynamic approach to our patients. And so again, for the monitoring, that as I told you, I think it's one of the most exciting field of the lung ultrasound for the cardiologist by now, but not only for the cardiologist. We have some specific good characteristics of lung ultrasound that makes this tool very appealing for the monitoring. And the first of it is the bedside. We do this clinical ultrasound. Okay? We do that at the bed of the patient. We don't have to call a radiologist to do this ultrasound. It's us. So we go to the bed of the patient and we do the examination. It's a low-cost examination, doesn't use ionizing radiation, and as we have seen, it is very dynamic. And again, this is perfectly in the line, in the philosophical approach of the clinical ultrasound, which is the same thing as saying bedside, since we know that in Greek, kline means bed. So when we say clinical ultrasound, actually it means that it is the exam that we do at the bedside of the patient. Okay, so moving on with our patient, we have done the diagnosis, we have monitored the patient to follow up the congestion. We can also use lung ultrasound from a prognostic point of view. This may be not so apparently important in acute conditions, but it can be very, very relevant in a long-term approach to our patients. And a couple of years ago, I published this paper showing that if you have patients hospitalized for acute heart failure, and if you do the lung ultrasound the last day of hospitalization, so when the patient is ready to go home, the patient is fine, no dyspnea anymore, no low extremity edema, the chest X-ray has improved, so all the doctors are happy and send the patient home. So in that case, if you still have more than 20 B lines, you have a much higher probability to be readmitted for the compensated heart failure in the next 3 months. And on the other hand, at least in my population, after 3 months, none of the patients who went home with less than 20 B lines were re-hospitalized for the compensated heart failure. And interestingly enough, very, very similar data were found in the same period from another group. a French group, and this is the same. So B lines, the day of discharge, can predict the new hospitalizations for heart failure in the next 3 months. The cutoff can change a little bit. It depends on the study population you have, and of course these numbers are indicative somehow. So there's not so much different from 20 to 30 B lines, but of course there is a difference between 0 or 5 or 10 B lines, and if you have 30 or 40 B lines. And this is true also in outpatients. So if you have patients coming to your ambulatory office for heart failure, even when they are asymptomatic, if they have lines, this is a very strong predictor of a new hospitalization of heart failure. These are the data of Elkeblatt, published in the European Heart Journal, and we had very similar results also in our cohort of patients, again, outpatients coming to the ambulatory office. If they had more than 30 B lines during the ambulatory office visit, they had a much higher probability to have a new acute pulmonary edema in the next 4 months. And here again, the ones who had less than 15 B lines, none of them had a new decompensation in the next 4 months. And the prognostic relevance is true also for the dialysis patient. Okay, so you see very similar Kaplan-Meier's also for patients on dialysis. This can be useful because we know that persistent pulmonary congestion in patients on dialysis, even after the dialytic session, is a bad prognostic indicator. So everything is very nice, of course, but there are a lot of limitations of the use of B lines in heart failure, and we have to know them. So at the moment, we have quite many studies, but we don't have a real randomized study, okay? And although, as I told you, we start having some small results about discharge time and so on, we don't have a clear paper demonstrating an improved outcome using lung ultrasound to titrate therapy in heart failure. So it means that we know that if you have more B lines, you have a worse prognosis. But we still don't know that if we treat more aggressively that persistent congestion, you may have an improved prognosis. This is the kind of information that we are waiting for, but is missing at the moment. The scanning scheme is not always the same in the studies, although there are 2 main scanning schemes that have been used. So also the cutoff values can change in some studies. And of course, there is a problem of specificity, which is very important and is something that we have to know when we do lung ultrasound. And the lack of specificity is intrinsic in the nature of B lines. So B lines are not a sign of cardiogenic interstitial edema. B lines are a sign of a partially deaerated lung, okay? So we usually find it in any conditions that address the interstitium of the lung. Cardiogenic pulmonary edema, but also non-cardiogenic pulmonary edema, as we have seen, but also interstitial pneumonia you may see with lines, or pulmonary fibrosis, okay? Just to give you a look on how a pulmonary fibrosis, a severe idiopathic pulmonary fibrosis looks like. This is the patient with a lot of honeycombing, a lot of fibrosis in the lung, and you see many B lines, almost a white lung. And again, you see that very, very, very abnormal pleural line. So just from a sonographic point of view, this is very similar to the acute respiratory distress syndrome, but it's not, okay? This is a pulmonary fibrosis. But this is to tell you that when you see B lines, you have to make a differentiation of which kind of B lines you are seeing. You cannot jump to the conclusion that is cardiogenic pulmonary edema. Just a note about the use of lung ultrasound for interstitial lung disease, which is not cardiogenic. There are quite a lot of data now, as you can see from this review from our group, and you may see that there are a lot of studies at the moment addressing the use of B-lines in interstitial lung disease, especially in connective tissue disease associated interstitial lung disease. So if you see a lot of B-lines and this doesn't match at all with the clinical pictures, always think that this could be an interstitial lung disease, okay? But B-lines are not only heart failure, again, for the cardiologist also. So it's true that most of our patients are here, but again, we also have a lot of patients who have heart failure and are on dialysis. We may have patients with acute respiratory distress syndrome. Again, we may have the chance to see patients with interstitial lung disease. And there are a lot of other applications of B-lines that are emerging month after month, for example, in pregnant women with preeclampsia. So we don't have to limit our use of B-lines only to heart failure. And we don't have to limit our use of lung ultrasound to B-lines, because that would be a big pity. And so even if you're not an intensivist or an emergency physician, and you're just a cardiologist seeing very similar patients, it can be very useful for you to see and to know how pneumothorax looks like on ultrasound. Or it can be very useful to know how a pneumonia or a pulmonary infarction looks like on ultrasound. So my advice is that any physicians you are, when you learn lung ultrasound, you don't have to focus only on one pattern, only on one sign, but you have to learn lung ultrasound, the whole thing in itself, because this is the approach we have to have in this case, okay? So, methods. I know you already know something about that. This is just quite a funny video, which is on YouTube with a very young myself. And you see that we do the lung ultrasound examination, putting the ultrasound probe in the intercostal spaces. I do prefer the transversal approach, which is the one putting the ultrasound probe parallel to the intercostal space. I prefer this much more to the longitudinal approach because I don't have the rib shadows. But of course, both approaches are valid, and they also have sometimes different meaning according to the clinical picture. And there is this very comprehensive scanning scheme we usually follow for our cardiological patient. This is very useful for follow-up, but it's quite long and time-consuming if you're not very expert. So you can always use this 8-region scheme that was proposed by Giovanni Volpicelli, and in this case you choose the worst scenario for each region of both lungs, and this allows you also to have a kind of a semi-quantification of B-lines in a quicker time. This issue of counting of B-lines is something worth to spend a few seconds on, because if you are in intensive care unit or emergency department and you have to do a very quick diagnosis, maybe you just want to know if you have or not B-lines. But again, if you want to monitor a patient, maybe a semi-quantification of B-lines can be useful. Of course, it's not so easy to count the B-lines because they move a lot. So if they are still and they are separated, it's easy to say these are 2, these are 3. But B-lines move, B-lines overlap. And so one rule of thumb that we proposed a few years ago, but actually works quite well and has been followed by many different groups, is that you consider the percentage of white of B-lines you see below the pleural line and divide it by 10. It means that, for example, in this case, in the worst frame, you have about 100% white of B-lines below the pleural line, and we consider this as 10 B-lines. If you have about 50% of white of B-lines, as in this case, we consider that 5 B-lines. If you have 30%, it is 3 B-lines, 70%, 7 B-lines. It's not precise, it's not very precise, but it works and allows you to have a more differentiated information than just saying yes and no. Okay, so limitations. Again, I like to stress this. We all are very enthusiastic about lung ultrasound. It's really useful, but we have to know its limitations, otherwise we cannot use it properly. It's echo, so it has a kind of operator dependency, okay? Although I have to say that the inter-observer variability is lower than other ultrasound techniques, because lung ultrasound is quite easy. For example, for the V lines counting, we can have a very good performance even by beginner and even by using very simple machines compared to people who are veteran doing lung ultrasound using more these machines are now all quite old because the studies was done more than 10 years ago, but this is the same if you use a portable handheld machine and a very big sophisticated ultrasound equipment. So you don't need a sophisticated machine to do lung ultrasound, this is for sure. Then there are real limitations that sometimes are difficult to be overcome. For example, if you have a subcutaneous emphysema, you cannot do lung ultrasound because the air between your probe and the pleura doesn't let you see anything, okay, inside the lung from a physical point of view. There is the issue of the overinflation. So we know that our densitometer works when you have a decrease in the lung air content, but if you have an increase in the lung air content, you cannot see it, okay? So patients with COPD or emphysema, you may see a sonographic pattern which is very similar to the normal one. You cannot see them. Then obesity. Obesity is not an absolute limitation for lung ultrasound, but you have to be a little more skilled, okay? So you have to know how to push the probe in the intercostal spaces. Sometimes it can be a little more difficult, but you don't have to step back to do your lung ultrasound just because your patient is a bit more obese. And one problem that you may have, especially in patients in the intensive care unit, is that you need some physical space on the skin of the thorax to put your probe. So patients with a lot of bend and drainage sometimes are a little more difficult to be scanned. So we are approaching toward the end, and I would just like to tell you a couple of things about how we should imagine our lung examination, okay? So we all think that the best performance of lung ultrasound is when it is done inside a point of care ultrasound. And again, you have already heard a lot about this yesterday, but I like to remind that when we speak about point of care ultrasound, we consider a focused, goal-directed ultrasound, which is done at the patient bedside by the treating physician. It's not done by a radiologist. It is done by you, who knows the clinical features of this patient. And it is done to answer a specific clinical question. It is not the echo you do to an organ, it is an echo you do to a symptom, okay? And when it is multi-organ, of course, it's better. And we have a couple of very interesting papers where lung ultrasound was included in a point of care approach in the emergency department. And if you see here, if you compare patients with a diagnosis done with a standard strategy, so not including lung ultrasound, with a patient who had a diagnosis including lung ultrasound in the management, after 4 hours after admission, we had 64% of correct diagnosis in the standard group, and we had 88% of correct diagnosis in the study group with the point of care echo. This is very important. It means that, of course, we have done diagnosis even before we had lung ultrasound and point of care echo, but we can do better if we use it. And it's also important to remember that we don't have to do a whole body point of care echo to any patient. We have to adjust which organ we want to scan according to our main clinical suspicion. And these data have been recently confirmed by this paper by the group in Florence of Maurizio Detti, and the meaning is very similar. So They did this point-of-care echo on 2,683 patients coming to the emergency department, and what they found is that the average time needed to do the correct diagnosis was significantly lower when using lung ultrasound. So it was 24 minutes as an average compared to 186 minutes. So even if we still don't know if this approach can improve outcome, we know that we can save a lot of time, which also means save a lot of money, and likely doing the correct diagnosis before could bring a better prognosis to our patients. But again, this has to be demonstrated. So we are approaching to a new integrated ultrasound approach when we can scan any organ, whole body ultrasound. We don't have to do anything all the time, but we select the organ according to the clinical suspicion. And actually, this means that we are going to consider our probe and our point-of-care echo as the new physical examination, which doesn't mean that we don't use the stethoscope anymore. We still use the stethoscope because we cannot visualize the air increase with ultrasound, so we still need the stethoscope, but we have now a very powerful tool to do our enhanced physical examination. Actually, lung ultrasound could become the super stethoscope of the future, as I had the chance to say in this editorial about, again, the prognosis in heart failure, but we all know and we believe that this future is now, is our present. Thank you.
Thank you so much. Luna, can you hear me?
Yes.
Okay, I'm going to ask for the audience if they have some questions, okay?
Okay, sure.
¿Alguna pregunta? Yo creo que muchas. Aquí, doctor Figueroa, quisiera preguntar algo más específico. Puede hacerlo directamente.
Okay.
Sí.
Sí.
Sí tienes
Sí,
varias
sí,
preguntas.
varias.
Okay. I just need, Luna, if, one person, actually he is a cardiologist, is going to ask you something. But I need to know if you can hear him, okay?
Okay.
Okay, can you hear me?
Yes.
Okay, good. I have a specific question. How about patients with left ventricular heart failure and pulmonary hypertension? Are there any changes?
Yeah, but you mean post-capillary pulmonary hypertension, so pulmonary hypertension due to the left heart failure?
Yeah, the group 2.
Okay, yeah, so, well, there are no specific studies differentiating patients with or without pulmonary hypertension, but I can tell you in my experience, I used to combine these two information because sometimes they do not have the same dynamic response. So it's quite typical that the pulmonary artery systolic pressure, if you treat the patient, decrease, but the decrease is not so quick, whereas the lines tend to be much quicker. So, for example, after 2 or 3 hours, if you treat the patient in effective way, you see the B-lines decreasing at least at the apex of the lungs, maybe not at the basis, but at the apex, but the pulmonary pressure can remain the same. I think another important thing is that when you have patients where pulmonary pressure is not easily to be measured by echo, for example, you're not sure that you are well aligned, you see the Doppler trace, but you don't like it very much, it's not very clear, you can have the lung ultrasound as a kind of surrogate information. And we had data in stress echo patients, and we saw that actually during an exercise stress echo, we had, for example, in patients with mitral regurgitation, an increase in the number of B-lines, and these was very closely correlated to the increase in the pulmonary artery systolic pressure. But in those patients where we had difficulty to measure the pulmonary artery pressure during stress at peak exercise, we were very easily able to measure the B lines. So they are overall similar information, but in a single patient may have very different dynamics. So if you can, of course, and you're not in a very good situation, I advise to measure both, and even the inferior vena cava as well as the ionic crime. But if I had to choose just one of these, I have no doubt, and it's not because it's my field of interest, but as a clinical cardiologist, I would choose the B lines because they are much more dynamic than the other parameters.
Okay. And the other one is this useful in the acute coronary syndrome, especially with those patients not with ST segment elevation, those with unstable angina or non-QMI? Is it useful as a diagnosis or prognostic tool?
Okay, I like this question a lot because this is one of the fields where I think B lines can be really useful for the cardiologist. And the answer is yes. Can you still see my screen?
Yes, Luna.
Okay. So I have opened a paper that we published a few years ago on the prognostic value of a combined cardiopulmonary score, ultrasound cardiopulmonary score, in patients with acute coronary syndromes, including also non-STEMI. And we compared it with the Grace and Timmy score, and we found that the echo score was actually very powerful and better in prognostic as a prognosticator than the Grace and Timmy. And our echo score was done by the 3 echo parameters that were more powerful to predict prognosis, which were the ejection fraction, the TAPSI, as a for a function of the right ventricle, and this ULX is the old name of the B lines, so ultrasound lung comets. And apart from this paper, I can tell you that, as you said, especially in patients with non-ST elevation MI, but also in STEM patients, when in the acute phase, you are very concerned about the ischemia. You are not much concerned about the left ventricular function, the pulmonary congestion. And some of these patients have huge B lines, especially those patients who didn't have a previous heart failure state. So they had normal ejection fraction, so their capillary membrane is used to increase the left ventricular filling pressure, and so they can develop a pulmonary edema very easily. So in these patients, monitoring the B lines, even just at the beginning when they come with the acute situation, can be very useful, because maybe you can give a little bit of furosemide that otherwise is not so typical to give to these patients, because you are concerning about the acute ischemia. And I have to tell that in my personal clinical experience, this is really, really helpful.
Okay. Yeah.
Thank you so much, Luna. ¿Tienen alguna otra pregunta, doctor Figue? No, por allá. Sorry?
If you want, I can.
Yes, of course, please. Luna, Giovanni is gonna speak something, right?
Oh, good. I hope so.
No, not speak, just a question.
Just a question.
Oh, a question for me. Yeah, you're not that much expert in lung ultrasound, so it's nice that you make a question. Yes.
No. I saw in your slides that you said, speaking about limitations of lung ultrasound, that is very important, because we now have many people still staying outside lung ultrasound and making many criticism about lung ultrasound, saying that there are not randomized studies about lung ultrasound to be accepted. That is something that, you know, is, for me, is something that doesn't exist. I mean,
I know, and
no, because there is not only a scientific reason to say that. It's not scientific, but it's something linked with the psychology of the establishment. I don't know how to explain. Anyway, you said randomized studies. But what means randomized studies in your opinion? So
So
randomized studies, for me, in this kind of application in medicine, doesn't exist. So we cannot do a randomized study about lung ultrasound. So what do you mean about randomized study?
okay, what I mean, and now I will tell you what I think in general, but you know, because we have spoken about this many times together. In the specific case with randomized trial, I mean that you take patients with acute heart failure, which are hospitalized, and you randomize them to a standard branch, and you just follow up patients and you titrate the diuretic therapy according to the clinical situations, to the weight, to the symptoms, to the chest x-ray, exactly as you would do in your normal practice. And the other branch, you do this standard practice plus the lung ultrasound. You do the B-lines every morning during the round, and you decide how much the diuretic therapy to give and when to switch from the intravenous to the oral, for example, according to lung ultrasound integrated with the rest of the picture. I mean, it's not only lung ultrasound. And to see whether this approach would bring to a reduced number of hospitalizations after, for example, 30 days or 90 days, or if this could reduce costs because you send patients home, or most likely you will send patients home a little later, but maybe they're not coming back again. But this is what I mean with the randomized trial in this specific setting of monitoring and titrating diuretic therapy in heart failure. But I do agree with you that it's quite funny sometimes that we have to stress this so much, because most things that we use in our clinical practice for many years have never been tested, not even in non-randomized trials. So it's quite a fashion of our times, and it's nice from one side that we want to really assess from a statistical point of view the benefits of what we do, but it's also true that we cannot measure everything in medicine, and most of the things that we currently use have never been tested in any trial, but they work. Not all of them, but some of them work.
Okay, Luna, I agree with you, but this is a sort of misunderstanding, because this randomization is useful to assess the outcome of our patients. And I agree with you. I agree that there are not outcome studies on lung ultrasound, and this is the next step. But when they say that the validity of lung ultrasound has not been proven because there are not randomized studies, this is not true. This is the point. So when you showed your slide with first point randomized studies and second point studies on the outcome, they are the same. You should, otherwise there is a misunderstanding. We don't need randomized studies to assess the validity of lung ultrasound, because it is not possible to do randomization, because we compare lung ultrasound with chest X-ray, with CAT scan, and this cannot be randomized. You understand?
Yeah, sure. I know what you mean.
So the validity, the how to say in English,
tell her in Italian.
No. Anyway, the validity of the test is not possible to assess this in the randomization. Okay. This is possible to do with drugs. So you have a drug, you need to assess the validity of a drug, and you do randomization, placebo with the drug. This is the way to assess, and this is, of course, mandatory. You cannot assess the validity of a drug without a randomized study. But this cannot be done for lung ultrasound, because you cannot do randomization, lung ultrasound versus CAT scan, and chest X-ray versus CAT scan is not useful. You understand what I mean?
Sure.
Okay.
So otherwise, I miss think that you are in the side of those saying randomization.
Yes, actually, in the last few months, I'm changing my mind, Giovanni. You know, you know very well how I think about this issue.
Sorry, Luna. There is a resident, or cardiology resident, and he is asking some questions, right?
Okay. Hello, can you hear me?
Yeah.
Yeah. Hello. My question is, what is the value of the B lines in the lung ultrasound in the scenario of patients with ejection fraction, preserved ejection fraction heart failure? Those patients sometimes they start to be studying for dyspnea, and sometimes it's difficult to determine the origin or their dyspnea. There is some value of the B lines in this type of patients?
Oh yeah, it is exactly the example that I did in the presentation. Absolutely yes, because B lines and the extent of extravascular lung water is not related to ejection fraction. I mean, so it is a kind of information that is additional. And as I said, I think in this typical situation, as you are saying, it is even more useful because it's not so clear that you are expecting B lines. So yes, and it's the same for diagnosis, for monitoring, and also for the prognosis, because in the studies that I showed you, some of these studies included both patients with preserved and reduced ejection fraction. And I can tell you, I have an analysis of my data dividing these two categories of patients, and there are no differences actually in the behavior. So no matter what your ejection fraction is, so no matter what the cause of heart failure is, the B lines are present when you are decompensated, and they decrease during the hospitalization, and the ejection fraction is not relevant here. It's the degree of extravascular lung water which is relevant.
Okay, thank you.
Okay. Otra pregunta. ¿Nada? ¿Todo está bien?
Okay. Antonio, I expect a pregunta from you.
No, well, there are a lot of questions, Luna, but I have read your...
One, not a lot. No.
Okay, Luna, I have read a lot of your papers, of course, and I am very interested to do the B lines as a prognosis in patients into the ICU. Actually, when I was studying echocardiography with one of my masters, who is present here, we had a patient doing echocardiography as an outpatient, and at the same time, the patient started to have chest pain, and at the same time, where we are doing the echocardiography study, at the moment when the patient started to mention chest pain, the B lines appeared in all the lungs, okay, and diffuse interstitial syndrome. And it was very exciting to see how the B lines appeared at the same time the patient mentions the chest pain. Okay, and maybe the patient doesn't show a low oxygen saturation or even struggling to breathe. And we saw in that occasion, we saw immediately the appearance of B lines in his lung. And it was very demonstrative how the B lines can appear without any symptoms from the patients, and in a preclinical setting or a preclinical scenario.
Probably this patient was Luna was speaking about. I say that probably this patient was the one you were speaking about a few minutes ago, with very, very sensitive to B lines,
because they're
yes, and actually
paired, they are, it is exactly, I mean, this is a surrogate for an ischemia test, and it's true, we saw this in many patients during stress echo, and I agree with you that it's quite astonishing the first time, because you don't expect them to be so dynamic, not only in going away, but also in coming up. And it's how much the system is, how do you say, same for physical. Soon you have the extravascular lung water. This is very typical, and it's a sign of how much the lines are dynamic. And I think it can be also a prognostic factor in these ischemic patients, because of course if you have a patient who has wall motion abnormalities but is used to that and doesn't develop pulmonary congestion, it's much safe somehow. If you have a patient who has acute ischemia and also acute pulmonary edema, those patients are very bad. Can you still hear me? Uh-oh. I cannot hear you anymore.
Okay.
Now
okay. I couldn't hear you anymore.
So Luna, please tell all the great experts in the European Society of Cardiology that we don't need randomization to demonstrate that this is valid.
No, I agree, we don't need it for the validity, for the diagnosis, but it would be nice to have a randomized trial for the follow-up.
Validation is already done.
Yeah, no, I agree with the validation, of course, it has already done.
Okay, Luna. I think the lung ultrasound can be very useful for the cardiologists, because they see patients as ambulatory or inpatient, out patients, and they can stratify the risk for the future. You know, you have written a lot of this topic. So, well, I think there are no more questions. No. Well, the cardiologist is gonna ask something, right?
Okay.
Yeah, that's it. Does it correlate linearly with biomarkers, heart failure or ischemia?
The BNP and so on.
The BNP or troponines or CKMB. Does it correlate?
Yes, this is another important question. And the answer is similar. So it is yes. You have, I'm showing you, if I can find it easily. Yeah, again, our paper with a correlation between B lines and NT-proBNP. This is quite an old paper now, but we are not the only one who did it. And the value of the NT-proBNP compared to B lines. So if you compare B lines and NT-proBNP on a large number of patients, you find a significant correlation. And the strength of correlation may vary from, I don't know, 0.4, 0.5, in some settings can be even higher, 0.6, 0.7. But in the single patient, this is exactly the difference between hemodynamic and pulmonary congestion. So BNP is a sign of hemodynamic congestion, but you may have very high BNP without extravascular lung water, because your heart is not working well, and you have increased stiffness, and you have increased left ventricular filling pressure. But not necessarily you have the B lines, okay? So what is very useful for the cardiologist, if you have both information, one is more a sign of hemodynamic congestion, the other one is a sign specific of the extravascular lung water. And this is not only useful when you have B-lines. In my experience, this is especially useful when you don't have B-lines. So, for example, you have a patient with a very low ejection fraction, with a very high BNP, because, of course, these patients have a stretching on the myocytes and high left ventricular filling pressures. But sometimes these patients do not have extravascular lung water anymore because they get a lot of diuretics, they're very chronic. So in this case, this discrepancy between high BNP and no B-lines can be very useful to titrate the therapy. But they are, I mean, overall in a big population, of course, they are correlated.
Okay, thank you.
Sorry, because maybe you will have patients with hemodynamic congestion, and these patients don't necessarily have pulmonary congestion, and you have written a lot of this specific topic to differentiate between hemodynamic congestion versus pulmonary congestion. And the patients who have pulmonary congestion, the prognosis is worse. Okay?
Exactly.
It's worse. It's worse. Okay. Luna, I really, really appreciate your attention. Thank you so much for accepting this conference.
No, it was my pleasure to be here with you. Thank you, and have a nice day. It's quite late now in Italy, so I'm going back home now, but you have a full day to learn a lot of interesting things about lung ultrasound. Okay?
Okay, thank you so much. Giovanni, do you have a commentary or no? I don't know. It's okay.
Commentary. I know she is very busy because there is Bernardo waiting for her. So no more comments.
I'm a little child.
Okay, Luna, I'm gonna finish the webinar. Okay.
Okay, great. Thank you so much.
Thank you so much.
It was great to be with you.
Thank you.
Okay, bye-bye.
Bye bye. Bye bye.